I will call Dr. Manju for the next session.
Good morning. Myself is Dr. Manju, working as a glaucoma consultant in Area Eye Care, Thrissur. Today we'll be discussing structure-function correlation in glaucoma. Glaucoma is defined as a disturbance in the structural or functional integrity of the optic nerve that can be usually arrested or diminished by the adequate lowering of IOP. There are mainly two things. There can be a structural or functional integrity change, disturbance in the structural or functional integrity, and the modified risk factor is a IOP that's given in the Becker and Schaffer. And diagnosis of glaucoma basically consists of structural changes, analysis of the structural changes and the functional changes. Structural changes is done by the optic nerve head analysis and the OCT analysis, and the functional changes by the visual field analysis. When you analyze the optic nerve in the slit lamp with a 90D lens or 78D lens, these are the factors which we analyze basically, and the important ones are regarding glaucoma are the neuroretinal rim and the retinal nerve fiber layer. Our retina consists of about 1.2 million neurons, and this is situated in the optic nerve head in the neuroretinal rim. So if you have a larger disc, you have more space to accommodate these nerves, and you may have a larger cup. But in a small persons with smaller disc may have a smaller cup. But if you see a larger cup in a person with a smaller disc, you should be suspicious of glaucoma. And a disc is usually vertical in shape and the cup is horizontal in shape. But when you see cup becoming more vertical, it means there is loss of neuroretinal rim, either superior port or inferior port, and is basically suspicious of glaucoma. CD ratio is something which we use for screening, like it's a very sensitive entity, but it may not be specific. Like even if you see a larger CD ratio in persons, if they have a normal neuroretinal rim, they may not be having glaucoma. Similarly, like in this case, this person is having a smaller CD ratio, that like 0.3, but there is a loss of retinal nerve fiber layer. Similarly, in this case, where there is an RNFL defect, 0.5 cupping, but there is an RNFL defect, and obviously in the case of a 0.9. So whatever may be the CD ratio, there is chance of having glaucoma. Next is a neuroretinal rim, which is little more specific. It usually obeys an ISNT rule, inferior more thicker than the superior, then nasal and temporal. If there is a reversal, it means there is a thinning at the superior and inferior port, producing a notching, and that is little bit more specific of glaucoma. And more specific one is a retinal nerve fiber layer defect. Usually, retinal nerve fiber is whitish in color and have a glistening structure. When there is loss of retinal nerve fiber layer, it becomes darker and it can have a wedge shape. Like in this case here, there is a wedge shape, darker striations. That is suggestive of a retinal nerve fiber defect. And if you have any doubt, you can put a red-free filter, and it's a little bit more clear, and it will have a blackish wedge-shaped striations you can see. And for the quantitative analysis of the structural defect, you can do a OCT of the retinal nerve fiber layer. Before analyzing any OCTs, make sure the identity of the patient and more specifically age of the patient and acceptability of the scan, that the quality of the scan, anything more than 6 is acceptable. 6 or more is acceptable. And then there will be a retinal nerve fiber thickness map, which indicates the total thickness of the retinal nerve fiber layer, or the NFL thickness map, and it will be compared with the age match controls, giving a retinal nerve fiber deviation map or NFL significance map. And from this, if you have any, if the patient is having any retinal nerve fiber defect or thinning, it will be indicated in red color in the RNFL deviation map. And there will be RNFL quadrant map, where the thickness of the retinal nerve fiber layer in each all the 4 quadrants will be given. In glaucomatous patient, there can be a thinning of the retinal nerve fiber layer at the superior port or inferior port. That is the RNFL quadrant map. And then there is an RNFL clock cover map, where retinal nerve fiber thickness in each clock cover will be given. And in glaucomatous patients, if there is any thinning in the supratemporal or inferotemporal part, is more suggestive of glaucoma. Supratemporal or inferotemporal or superior or inferior. These are the quadrants which is more suggestive of glaucoma. The retinal nerve fiber fibers are the axons of the ganglion cell. So, if there is any destruction of the nerve fiber layer, there can be any destruction of the ganglion cell or its axons. These ganglion cells are mainly situated at the macula. So, analysis of the ganglion cell and interplexiform layer thickness at the macula can give an idea of the status of the nerve fiber layer. So, it's important to note the direction of the fibers. This is the direction of the fibers. So, if you note any thinning of the retinal nerve fiber layer in the inferior part, there can be a thinning of the ganglion cell layer in the mainly in the inferior or inferior nasal part. So, the direction of this retinal nerve fiber layer is important. The anatomical direction and anatomical location is important. Similarly, in this case, this is the direction of the fibers. OCT is an objective test. There can be segmentation errors and artifacts. Like in this case, the patient had a blink, and if this is coming in the scanning area, you can have a false positive results. Like there is a thinning noted in this clock cover, but it may be due to this artifact. So there can be some artifacts and segmentation error. The functional analysis is mainly done by the visual field. 30-2 which analyze 76 points with 6 degrees, and in glaucoma we mainly analyze the 24-2 which contains 54 points and 6 degrees, in which all the edge points in 30-2 is removed and only the nasal part is kept to get a first nasal step is the first field defect which may appear. So to get that, only the nasal part is scans up to 30 degree. And then is the 10-2 with 68 points 2 degrees, and macular threshold or 5-2 16 points 2 degrees. And there is 24-2C which scans 24-2 with additional test points at the center. That combines almost like combining 24-2 and 10-2. So there can be various field defects like paracentral scotomas, that is at within the central 10 degrees, and nasal step, that is a relative depression on one horizontal hemisphere, or an arcuate scotoma, or there can be advanced field defects like a threat to fixation if any one of the central points in 24-2 is involved, in which we may do a 10-2 field to see whether there is any involvement of fixation or any one of the central points in 10-2 is involved, and little bit more advanced like to see a macular split. If 5-2 is done, you can see you need 2 out of 4 central points is involved. It is called a macular split. All these are like various field defects. And in visual field also you can have some artifacts, like in the case of a rim artifact, and in case of high false positive errors you can have white scotomas, and in high false negative errors you can have a clover leaf patterns. So what's the importance of structure function correlation is that these are the 3 things which you see. So there should always be a correlation between neuroretinal rim thinning and the localized RNFL which we see in the OCT, and any visual field defects which we see. So this helps in early detection and accurate diagnosis, to assess the severity of the disease, and it helps us to know where to look for any progression, and to assess the treatment efficacy, and to know the pathogenesis of the disease. And this was done by a study by Kanamori et al., where they have taken entire 24-2 and divided it into various clock hours, and this they have superimposed on the 24-2 field, and has seen in every patient in each point which point is giving a significant outcome. With that, along with the Hood et al., they have given a map where they have combined the 24-2 with the RNFL. So if you see a RNFL defect or RNFL thinning in this point, where to look for the visual field defect? This is exactly like correlation of the RNFL with the visual field. So always when you analyze a patient, you should look for where the RNFL or thinning is and where the visual field defect is. And typically in this, 1 and 4 are non-glaucomatous, more suggestive of any neuronal thing, and any change of 3 decibel indicates a 50% reduction in the retinal ganglion cell. So, for example, there is a retinal nerve fiber layer thinning, and there is a RNFL thinning in inferior part, and basically these two are the areas of thinning. So we have to look for a field defect in this area, and the patient is having a field defect in this area. So it's basically like there is a correlation between the structural damage and the functional damage is more suggestive of glaucoma. Similarly, in this case, there is an RNFL defect and there is a corresponding ganglion cell defect, and patient is having an RNFL thinning, and this is the area where there can be a field defect, and the patient is exactly having a field defect in this area. So this is like a correlation between the structure and function. Similarly, this patient also, there is only small RNFL defect, there is a small Glaucoma defect, and this is the area where there can be a thinning, I mean the field defect, and the patient is having a field defect exactly at this area. This also, like the patient is having a thinning in superior quadrant, and if there is a thinning at that area, these are the two areas where there can be a field defect, and the patient is starting to have a field defect in this area. Is one more patient, there is an RNFL defect in the left eye, and this is the area where there can be a field defect, but the patient is having one more like scotomas in this area. This can be like an artifact because the patient is not having in the corresponding area. So when we repeat the field in the left eye in this patient, this field defect or this artifact may disappear. It's important if you analyze the progression, because if you take this field as a baseline field and analyze progression, the progression analysis may not be correct. So in these cases, better to repeat the field and keep that field as a baseline field and analyze progression in this patient. So although the structure function relationship is related to the loss of ganglion cell, there can be some it can be variable and imperfect because of the variability of the test and measurement of the structure. Like RNFL defect is measured linearly and the visual function is measured on the decibel scale. So there is measurement scale difference, and there can be some inter-individual physiological variation, and there can be lack of precise co-localization between the measurements, and there are entities like pre-perimetric glaucoma where there is a structural damage but the functional damage is not yet there because the retinal ganglion cells have more functional reserve. So even though there is loss of retinal ganglion cell, remaining ones are taking that reserve, and visual function is not yet affected. So the future dimensions are actually, it's like quantification of the functional damage and the structural damage. This can be incorporated into the AI and machine learning algorithms to analyze and identify patterns and correlations, and can predict the disease and give a tailored individual treatment plan. And if you can include other multimodal data like OCTA, genetic information to this, which can increase the accuracy of the diagnosis and helps in monitoring the disease. And with all this data, if you do a long-term longitudinal studies, which it will help us to do to know more about the pathogenesis of the disease and the patterns of progression. And there are various patients, like there are various patterns, like there can be faster structural progression, but functional progression may not be that much, or functional progression is faster than the structural progression. If you know the pattern of your patient, and you can give a structured, like tailored medicines for the patient. So personalized medicine and drugs. So in future there can be drugs which can address the structural damage and which can address the functional outcomes like that. And if you know the pattern of your patient, you can change or tailor your medicines or treatment plan according to that. So these are the take-home messages. OCT and visual field are complementary diagnostic tools, which helps in the early detection and monitoring, and also in the progression assessment to know the rate of progression in each patient. It helps to plan early interventions, but there can be some individual variability, and after all, clinical correlation with other factors is very, very important. Thank you.